Welcome to this video on how we support the kidneys in intensive care when patients develop severe kidney disease and renal failure. This is a follow-on from the previous set of videos that we did looking at potential reasons why patients with, say, COVID-19 disease develop kidney failure. And this particular talk will concentrate purely on how we support the kidneys, the machines that we use. And in order to understand that, we need to see how the kidneys themselves actually function and what their roles are in the body. And we go through that in a huge amount of detail in the previous video, so please go and have a look at those before watching this one. We'll concentrate on how the kidney machines in intensive care support kidney function and mimic some of the functions that the kidneys do. And finally, we'll consider a few questions on how we move patients on from intensive care if they've got ongoing renal failure. You might remember this picture from the last presentation, and it really highlights the vast number of different roles that the kidney has within the body. We talked a little bit about the endocrine function, so the fact that it produces hormones that can control blood pressure and produce red blood cells in the body and prevent anemia. Importantly, we talked about how it regulates the amount of fluid inside the body and also the salts within the body. It can be used to control blood pressure, the acid levels of acidity within the body, and importantly in medicine and especially in intensive care, it helps remove drugs that we give the patient. So if the kidneys aren't functioning well and we don't replace the function of the kidney with the kidney machine, then we can get toxic accumulation of the drugs that we give, which may cause further harm to the patient. Now, lots of patients develop a little bit of injury to the kidney when they're very unwell. And that in and of itself doesn't necessarily mean that we need to put the patient on a kidney machine. The reason we put them on a kidney machine or a dialysis machine is that they start to develop the problems with accumulation of the things that the kidney would otherwise get rid of. And so you can see here a table of the indications for starting a patient on renal replacement therapy, i.e. putting them on a machine that basically does what the kidneys would normally do. So the first thing is anuria or oliguria. What that essentially means is that the kidneys normally produce urine. So if they stop producing urine, they stop removing fluid from the body. So if you produce less than 200 mils over 12 hours, then it might indicate that you're accumulating fluid, because usually you take more than about 200 to 500 mils in a day of fluid. So if you're taking less than that, then any additional fluid that you're taking in isn't getting excreted out, and so will accumulate within the body and cause the patient to become edematous, i.e. puffy, swollen. And if you imagine that their skin gets swollen, exactly the same thing happens within the lungs, the heart and other tissues. And so everything becomes swollen and doesn't work as well. So if patients are getting very fluid overloaded, then we may consider putting them on a renal replacement machine, a dialysis machine, to help get rid of that fluid because the kidneys can't do it anymore. A really important reason for putting patients on dialysis or renal replacement therapy is something called hyperkalemia. One of the salts in the body, potassium, is found in very low concentrations in the blood, and it's kept low by the kidneys removing it from the blood all the time and excreting it in the urine. So if the kidneys stop working, the amount of potassium will start to increase in the bloodstream. And if you get high levels of potassium in the bloodstream, it can cause certain cells not to function well. And the cells that we're particularly worried about not functioning well are the heart cells. So often, when patients develop very high potassiums, they can then get funny rhythms within the heart, and the heart itself can actually stop beating altogether. So it's very dangerous. And so one of the main reasons we put patients on renal replacement therapy, i.e. a dialysis machine in intensive care, is to try and prevent fatal hyperkalemia or high potassiums. We mentioned also that the kidneys will manage the pH of the blood, how acidic it is. The natural tendency of the body is to produce acids because there's metabolism of proteins, and the normal metabolism of things produces a lot of acid. That acid is usually removed by the kidneys. However, if the kidneys aren't working, you're going to get an accumulation of acid, hydrogen ions, in the blood. Now, by accumulating all of this acid, you make the whole body more acidic. And we talked a little bit about the importance of enzymes in the last talk. Well, enzymes need a very specific pH range in order to function well. And if we're outside of that pH range, then the enzymes don't work well, which means the cells don't work well, which means you develop organ failure. So, another reason for starting renal replacement therapy, i.e. to replace what the kidneys would normally do, is if you get very severe acid levels. So a pH of less than 7.1, one would almost certainly start the patient on renal replacement therapy. You can also get an accumulation of different toxins, and one toxin that we're particularly worried about is urea. Urea is a breakdown product of proteins. And in the body, there's constantly the breakdown of proteins and then the formation of new proteins. So there's constantly the production of urea. Normally, the kidneys would remove this very efficiently. However, if the kidneys aren't functioning well, then you can get an accumulation of urea, and you can get the so-called uremic complications. Encephalopathy means that the brain isn't working well. If there's a lot of urea in the body, it can go into the brain tissue and then suck water into the brain, causing the brain to swell. And when the brain swells, it doesn't work as well, so patients become drowsy, confused, and eventually become unconscious. So encephalopathy is a serious complication of uremia, a high blood urea level. You can also get swelling of other areas. So pericarditis, this is the swelling of the covering around the heart. If you imagine that the covering around the heart gets swollen, it'll squeeze down on the heart and not allow it to pump as well. So again, a very serious complication of uremic patients. And then we can also use it to filter out drugs. So some patients can take drug overdoses, and classically the drug that's overdosed is aspirin. And if you get an overdose of that, sometimes it can stop the kidneys from functioning well. And so you might need a kidney machine, a dialysis machine, to help remove the excess drug and therefore allow the kidneys to start coming back and functioning. And finally, those patients with inflammation, sepsis, their kidneys may not work well either. And if you remember from our last talk where we talked about some of the reasons why patients with COVID-19 develop acute kidney injury, well, many of those are the same reasons that patients with bacterial pneumonias or bacterial infections can develop kidney injury as well. And so for all of these reasons, we'd need to start thinking about whether to put a patient on a kidney machine, a dialysis machine. So then begs the question, what exactly is a dialysis machine? Anyone who's seen any pictures of intensive care or been to an intensive care will sometimes see these big machines here. And this essentially is the machine that does what the kidneys do. If you imagine what the kidney does, all it does is it takes the blood, filters out all of the bad bits of fluid, takes it out, and keeps all the good bits of fluid. And that's all this is doing as well. Now it has to pump the blood out of the patient's body, then it runs it through the circuit, and this particular bit here, this is the actual filter. This is what does all of the work. The rest of this whole thing is all pumps and adding fluids to the blood that goes back in to make sure that it's nice and balanced, so you've got exactly the right amounts of the different salts and exactly the right amount of water coming back into the blood stream. So out of this whole big machine, that's all to do with renal replacement therapy, the bit that actually filters the blood is this bit here. Now, to get a bit of a better idea of exactly what the renal replacement machine does, it's worth having a look at the picture here. What we do is we place a big line into the patient's neck, into one of the big blood vessels. And what we can do with this big line is we can suck blood out and then put it through a machine and then push it back in. So it's got two holes, two lumens, one to suck blood out and one to push blood back in. So let's have a look at this system. So let's imagine we've got the line in and we suck blood out. So we suck the blood out, and the way it's sucked out is through a blood pump that you see here. So this pump will produce a negative pressure and suck blood up. And then it'll push it down through this filter. And in the next video, we'll show a little bit more about exactly what this filter does and how it gets rid of the bad bits of the plasma, the water in the bloodstream, and keeps all of the red cells in, and then replaces it with some nice clean fluid, which then gets pumped back into the patient's body. So this is continuously happening. So you're continuously dragging blood out of the body, pushing it through this filter to get rid of all the bad stuff, and putting in all the good fluid back in. So you've got nice clean blood that then goes back into the patient's body. So let's talk about it in a little bit more detail. So it's worth trying to think about what we're trying to achieve by putting a patient onto a kidney machine or a dialysis machine. Well, one thing we need to do is to remove fluid. We know that the kidneys produce urine and get rid of excess fluid. If the kidneys aren't working well, we need to get our kidney machine to do the same thing. So one of the roles will be to get rid of excess fluid. We also want to remove toxins that are dissolved in the water part of the blood, the plasma. And we want to try and make sure that there's not too high amount of potassium, there's not too many hydrogen ions making the whole fluid acidic. So we want to balance all the salts in the dissolved portion of the blood, the plasma. So this is a picture looking at all the different components in the blood. So if you imagine this being sucked out of the patient's body, we've got red cells, we've got white cells, we've got little platelets there, and then we've got albumin and other proteins. And then you've got this yellow stuff here, which is the plasma. That's the water bit. That's the bit that we actually want to try and filter and clean and put back in without all the toxins and with a balanced number of salts. All the rest of it, the red cells, the white cells, the platelets, the albumin, we want to try and keep all of that as is. We don't want to get rid of that. We don't want to lose any, and so we need to try and keep that all inside the patient. It's worth trying to think a little bit about the blood in terms of its different components. So you've got the red cells, which form about 40% of the patient's blood. If you take, say, 100 mils, spin it down, about 40 mils of it is going to just be red cells. And then you've got other stuff in the blood. So you've got thrombocytes, which are the platelets, which form about 2%. So you'll get about 2 mils. You've got about 4% protein. So this is things like albumins and immunoglobulins. That you'll get about 4.4 mils of. And then you've got a little bit of dissolved fat and other things in there as well, which form the rest of it. So what you end up with is about 50% of it is the water, the plasma. And inside the plasma is dissolved all of the toxins. Inside of the plasma is dissolved all of the salts. And the plasma gives the fluid volume of the blood. And so if you've got too much water, you can take some of this plasma out. If you've not got enough plasma, you can put some fluid into this to give exactly the right amount of fluid that the patient needs to make sure all of their blood vessels are nice and full of blood. So we can summarize it by saying that what we're trying to do with renal replacement therapy is to get just the right amount of clean blood. That means blood with no toxins and the correct levels of salt. And we want not too much fluid, but also not too little fluid. We need just the right amount. And this is how we achieve it. So if you remember from the last picture, I talked about the fact that there's a filter within the dialysis machine that does the main bit of removing the bad plasma and getting the salt levels and the fluid levels exactly right. Well, this is a schematic diagram of that. So let's imagine you've got blood coming in from the patient's body and it goes into this filter. And in the filter, what you've got is lots of ceramic straws with little holes in it. And what those holes do is they prevent all of the red blood cells, the proteins, the white cells, the platelets from leaking out into the surrounding area. So what we want is we want water to flow into this area in between the little straws. And we want all of the red cells to stay within the straw itself. And it's this blue area that all the plasma leaks out into. And that's the stuff that we want to clean out. Now let's think a little bit about how we do the different functions of what we want the renal replacement therapy, the dialysis machine, to do. And the first thing would be to try and get rid of water. So how do we get rid of excess water? Imagine a sponge. If you've got a sponge that's full of fluid, how do you get rid of that excess fluid? Well, what you do is you squeeze it, right? And if you squeeze it, all the water comes out of the sponge. Well, exactly the same thing can be done within the filter itself. If you have a look at this is where all the blood is flowing through this straw, the ceramic straw. And this ceramic straw has little holes in it, so it stops any of the red cells from coming out. But it can allow water to come out. So if you imagine inside the straw, you've got the blood pumping through really fast, so you've got a high pressure inside here. Well, if outside you've got a low pressure, you're going to do exactly the same as what you would do if you were squeezing a sponge. You're going to squeeze the blood out from an area of high pressure inside the straw to an area of low pressure outside of the straw. And so you can get what we call convection movement of fluid outside into this area, the blue area, that then can be washed and cleaned, whilst keeping all of the red cells, the white cells, the proteins inside the straw, and therefore we're not going to lose it. So that's one of the ways in which we can get rid of fluid. And we can also get rid of the salts as well, which are dissolved in that fluid, and clean all of it out. The other way in which we can do it is by diffusion. So I want you to have a look at this picture down the bottom here. You've all done experiments where you've put little potato wedges into distilled water, and because you've got a high concentration inside the potato and a low concentration outside the potato, and you've got a semi-permeable membrane, which is the cell wall of the potato, if you've got the low concentration here, you're going to get movement of water through the semi-permeable membrane, because these solute bits won't be able to pass through the semi-permeable membrane. And what it's trying to do is to equalize the concentrations on both sides of the semi-permeable membrane. And so what you end up with is water moving out and filling up the high concentration area of the semi-permeable membrane. Well, if you imagine that, you can do exactly the same within the filter, because this straw, the ceramic straw, acts like a semi-permeable membrane. So if you imagine that you've got a high concentration of bad solutes and you've got a low concentration of good solutes here, you're going to diffuse these bad solutes out. But if you think about water, if you've got a high concentration here of water and a low concentration of water here, you're going to move water across. And so here you've got the nice clean water, which is going to move up into this area here with the blood inside. So you're going to diffuse clean water in, and you're going to diffuse out all of the toxins and solutes out. And so you can equalize them through that way. Now, imagine for a second that you've got a high concentration, you've got blood flowing through this way. And if you've got blood flowing through this way, and you've got a high concentration of bad solutes here, and a lower concentration of solutes here, and you've got clean fluid going this way, what you can do then is that the lowest concentration of the bad stuff is going to be here, and the highest concentration of the stuff is going to be here. Because if you imagine here, you've got a high concentration of bad stuff, which is going to move out. And so you can increase the gradient with which the bad solutes come out, so that you make sure the stuff at the end of the dialysis machine is the cleanest by moving it through in a countercurrent method to the blood that's going through the machine. It's a bit complicated, but essentially this is what we call a countercurrent method, where we can use diffusion to make sure we get rid of all of the bad solutes and put in the good clean fluid into the system just before it goes back into the patient's body. So let's think about it more schematically. So this is exactly what happens in a renal replacement therapy. So you have got blood coming from the patient, it's pumped, so it's sucked out of the patient's body, and then it's forced through this filter and then pumped back into the patient's body. So if it's forced through this, you're going to move solute through. It's like wringing that sponge. So immediately you're going to get efficient movement of fluid, plasma out. Now if you just squeezed fluid out, there's just going to be lots of red cells and proteins here. So we need some clean fluid to then put back in so that we can give the water component of the blood back. So this is what we call replacement fluid. And you saw that hanging underneath the machines in the picture that I showed you of a renal replacement therapy machine. And that clean fluid replaces the plasma that's in the blood. Now on top of that, what you can also do is increase the efficiency with which you get removal of all the bad solutes. Because however hard you push this, however much you wring the sponge, you're not going to get rid of all of the water. In that same way, you're not going to get rid of all of the plasma just by trying to squeeze it through. So what you can also do is pass clean water through this system, and by doing so, you're going to drag some of the bad solutes out that are still stuck in this side with the blood. And so if you do this the opposite direction to which fluid is going, the lowest concentration of the bad solutes is going to be just before it leaves the filter. And therefore you're going to make sure you've got the lowest concentration here, because you're going to drag everything across. And then as it goes this way, the concentration of the bad solute increases, and so then you get all of this removed. And this is the waste with the drugs and with the high potassium, the lots of hydrogen ions causing the acidity. So you can see how you can clean out all of the blood and then put it back into the patient. So by changing the amount of replacement fluid, you can either give a bit more fluid or you can take away a little bit of fluid. And by doing so, you can make sure they've got exactly the right amount of fluid that they need. If the patient's got lots and lots of fluid, they're very edematous, you can reduce the amount of replacement fluid you give. So say you take out 300 mils of the filtrate, so the plasma. Well, if you've taken out 300 mils, but you only give back 200 mils, that means every hour you take out 300 mils here, but you put in 200 mils here. Every hour you're going to be taking away 100 mils of fluid from the patient's body. And that's how we reduce the amount of fluid within the patient's body. However, if the patient's really dehydrated, then what you can do is, if you take out 300 mils of the plasma, you can put in 400 mils of fluid every hour. And therefore, now 300 is coming out, 400 is going back in, so now you're adding 100 mils an hour of fluid to the patient's body. So you can slowly increase up their blood volume levels. So if they're dehydrated, it'll improve their intravascular volume, the amount of blood within the blood vessels. And this is simply how that machine works. And all the pumps are really there just to pump fluid through and to pump blood through the machine. But that's all it boils down to. So then comes the question, well, how long do you do this for? And the honest answer to that is until the kidneys recover, if they do. And that's why in intensive care, renal replacement therapy is really just a holding measure. we still need to treat the underlying problem. So if the patient's heart isn't working well, we need to make sure that we get the heart functioning better, either by improving the blood flow to the heart or by giving medications to make the heart squeeze harder. If the patient doesn't have enough blood, we can give them blood transfusions, or we can give them IV fluids to try and expand their intravascular volume. If they've got inflammation, then we can give them treatment for the inflammation. If that inflammation is related to infection, then we can give them antibiotics if it's a bacterial infection. If it's a viral infection, we can give certain antiviral medications, or we just wait for the patient's body to fight off the virus. And if it's a vasculitis or an autoimmune condition, then we can give medications to try and dampen down the patient's own immune system to try and reduce the amount of inflammation that's occurring. If the patient's on drugs that have caused the kidneys not to work well, if they've taken an overdose of aspirin, for example, by clearing the aspirin, you're going to get the kidneys to start working again. So ultimately, you need to reverse whatever the underlying problem was that was causing the kidneys not to work well. And that's why we talked so much in the previous video in COVID-19, why it's important to understand what the underlying problem with the kidney is, because then we can treat it and therefore we can get patients off the filter. So based on this, it's worth having a little think about two specific questions. The first is, well, it's great if the patient's kidneys resolve and come back to normal again, but what happens if they don't? What options do you have? Now, some of you may have heard of dialysis. Well, that's one of the things, so it's worth having a little look at what dialysis is. And then the final question is, how can you do dialysis without taking blood out of the body? Everything that I described for you in intensive care, we have to take blood out of the patient's body, filter it, and then put it back into the patient's body. But there is a way to do it without even having to take any blood out. And it's worth doing a little bit of investigation to see if you can find a way of dialysing a patient without having to take any blood out of the patient's body.